Hi, everyone. Welcome back to StrokeSense, where we dig into the science and stories reshaping stroke care. I'm Soha.
And I'm Sohail, and today we're talking about how perfusion imaging and artificial intelligence are changing who gets treated and when.
Our special guest today is Dr. Albers, director of Stanford Stroke Center since the 1990s, and the principal investigator behind the DEFUSE trials that helped extend treatment windows for stroke. He also co-founded the rapid imaging platform many hospitals use today.
Dr. Albers, thank you so much for joining us today. Could you start off by telling us a little bit about how you got into neurology and what made you decide it was for you and what drew your interest towards perfusion imaging and utilizing new technologies?
Well, thanks for having me. It's really a pleasure to be on your podcast. I was really fascinated by stroke when I was a resident training at Stanford because it was a very common condition, but there was no treatments available at that time. And then we started doing research to see if we would be able to dissolve the blood clot or pull out the blood clot. But we realized that it was going to be really important to image the brain to be able to understand how strokes are evolving over time.
So, a lot of students listening know the phrase time is brain. Can you unpack what perfusion imaging adds and why and what a tissue clock is?
Yeah. So time is brain is the mantra of stroke treatment, that the sooner you treat the patient, the better. But what we realized is that the time for every different stroke is different. So, for example, some people, the brain tissue dies very rapidly, so there's very little time. But fortunately, other patients have good collaterals, other blood vessels that can bring in blood flow to help out the area that's being starved of blood by the blocked blood vessel. And for those patients, they have a much longer time. And we can talk about some of the studies that showed we can have tremendous success treating patients many, many hours after stroke onset if they're lucky enough to have good collaterals.
So it really varies from patient to patient, and good collaterals can actually benefit the patient.
Absolutely. It's going to determine whether we can have a successful stroke treatment or not. And what we want to do is rather than rely on just the time since the stroke began, we want to take a picture of the brain when the patient arrives in the ER, and we want to see how much salvageable tissue is present. If there's still a lot of salvageable tissue, it doesn't matter when the stroke started. It tells us that there's something that we can do to help that patient.
So, Diffuse 3 is famous in stroke circles. For the listeners who haven't heard of it, what did this study prove?
Yes, so Diffuse 3 was one of the first studies to be able to show that we could really expand the time window. At the time that we did the study, there was no evidence that you could treat a stroke beyond 6 hours. And most patients don't get into the hospital within 6 hours because a lot of people wake up with a stroke, or many people have a stroke far away from the hospital. So at this point, we were using catheters, a small tubes that you would put up into the brain to take the clot out of the brain. And the question was that if we use imaging to be able to identify who has salvageable tissue, can we treat these patients at long time windows, meaning up to 16 or even 24 hours after the stroke began? And that's what we did in the study. Half of the patients were treated with the thrombectomy, the clot removal procedure. Half of them were not. And we could see that there was a tremendous benefit all the way out to 16 to 24 hours if the patients had favorable imaging. And that's why we had developed the AI software to identify who has salvageable brain tissue and who doesn't when they come into the ER.
So that would be your software rapid, right? Automating those maps, and instead of your radiologist hand drawing the regions, the software kind of spits out color-coded core and penumbra volumes in minutes.
Exactly. Yeah, this is something that we started developing in the late 90s at Stanford, was to be able to take a picture of the brain and have automated software look at that picture and say, all right, this region is dead. We're not going to save that, but here's the region surrounding that dead area that's still salvageable. So if there's a substantial amount of salvageable tissue, those were the patients we put in the Diffuse 3 study, and we're able to show that those patients could have a huge benefit from having the clot removed, even in a late time window.
Wow, that's amazing. So, let's also dive into AI. Beyond perfusion maps, what is AI actually doing in stroke imaging?
AI is doing a ton these days in stroke imaging. So, in addition to identifying salvageable tissue, AI can identify patients who have occluded blood vessels. They can identify where the blood vessel occlusion is. It can tell you if there's a brain hemorrhage. It can identify if you have an aneurysm. And you can use the AI to communicate with your colleagues. So, if I get a call from a hospital that's far away from Stanford and they want to consider a transfer, before I even dial the ER, I can see on my phone all the images, whether this patient has a large vessel occlusion, how much salvageable tissue, is there any brain hemorrhage. I can get all that information and I can basically make a decision even before I've talked to the ER doc that this is a great patient to transfer. We can send the helicopter right away to get the patient.
That's fascinating. It seems like AI has come like a really far way.
Yeah, it speeds the process. With AI, we can treat much faster. As we said, time is brain.
But obviously, AI isn't perfect. So how do you kind of trust and balance and verify AI?
It's a great point. The idea is not to hand over everything to AI and let AI make the diagnosis. The idea is for the physician and the AI to work together. So if you look at the physician, they can miss some things. If you look at the AI, they can miss some things. But if you put them together, you get the optimal performance. So the goal is not to have AI take over our jobs, it's to make our jobs easier, faster, and allow us to look at the AI and say, hey, there's an artifact. That's not a real occlusion. Don't worry about it. Or, hey, I might have missed that aneurysm, but the AI pointed it out. So, again, it's the combination of the physician and the technology that's going to give you the optimal result.
So now, as we look into the future of personalizing stroke therapy, what's the next frontier? More precise drugs, better imaging? What do you think?
All sorts of things are happening. This field is moving very rapidly. So, we didn't talk about clot dissolving medicines. That's the other way. Rather than physically pulling out the clot, we can give an injection into a vein and try to dissolve the clot that way. There are new drugs that are more efficient at dissolving clots and safer because clot dissolving drugs have a small risk of causing brain hemorrhage. There's also a group of drugs called neuroprotective drugs that are going to allow the brain to live longer and have salvageable tissue for a longer time so that we can, again, even treat them later. There's new advances in AI to try to speed up the process even further. The AI can now pull information from the medical record and provide the physician with everything they need to make a decision very rapidly.
Wow, this is really truly fascinating. But for our listeners, remember, understanding fast is still the number one step.
Yep, absolutely. Again, time is brain. Great questions. Really appreciate being able to participate with you guys today.
Yeah, thank you so much for your time today. We truly appreciate the expertise you shared with us today, and we're sure our listeners are just as grateful as we are.
And for our listeners, remember, if you learned something, remember to subscribe and keep up with the ever-evolving stroke care.